Good morning and welcome to day 3 of the 2023 Within Health Summit. My name is Jamie Singletary and I am the Director of Clinical Brand Development for Within, and it is my pleasure to be your host this morning. We are joined today by our Director of Psychiatry, Dr. Sam Moss, who is going to be presenting on From Pills to Pillars, Medications in ED, and Building a Strong Foundation for Recovery. Before I turn it over to Dr. Moss this morning, I did want to go over a few housekeeping things. Just wanted to share that this is going to be recorded, so you will be able to view this presentation after we complete within 24 hours. Also, if you are working on CE credit or CMEs, please know that the email that you registered with for this presentation, you will receive instructions on filling out the evaluation so that you can download your CE or CME certificate. If there are any questions, I will have my information in the chat. If there are questions for our presenter today, comments or concerns, we encourage you to utilize the chat as well. And without further ado, I would like to turn it over to my dear colleague, Dr. Sam Moss.
Thank you so much, Jamie. Good morning, everyone. Thank you for being here with me this morning on this talk on medications on a Thursday morning. Before I begin, I do want to say that I cite some research studies in this talk. I encourage anyone who's interested in a particular study to reach out to me, and I'll be glad to provide the specific study. There are some limitations in research in our field, particularly that it's not always inclusive of all different populations and genders and ethnicities. So just something to keep in mind as we discuss some of the data. The title of my talk is From Pills to Pillars, Medications in Eating Disorders and Building a Strong Foundation for Recovery. Looking at our agenda today, I'll be discussing some of the learning objectives with you all. I'll briefly spend some time looking at the history of medication trials in our field, particularly in anorexia nervosa. Then I'll discuss some of the co-occurring conditions that are often the treatment target in our field to make sure we're all familiar with them. I will be doing a kind of an overview of commonly prescribed medications, some of their uses and clinical considerations to keep in mind, both for clinicians and also from a patient's perspective. And I'll be doing my best not to go into too much technical detail to make sure this talk is appropriate really for all levels and disciplines. In the fifth section of the talk, I'd like to talk a little bit about how we can personalize psychiatric treatment in our field. That's the pill, patient, prescriber, and partnership, where I'll be talking a little bit about deprescribing, genomic testing, and also the importance of the therapeutic alliance when it comes to medication management. Finally, a brief look ahead in terms of what's next in the field when it comes to medications and novel therapeutics, and hopefully we'll have a few minutes left for a Q&A at the end. Looking at our learning objectives, my hope is for you all to gain a bit of an understanding of the co-occurring disorders that are often present in eating disorders and can certainly have an impact on the severity and outcome of eating disorders. Furthermore, to be able to identify commonly prescribed medications and also to evaluate some of the benefits and drawbacks associated with the use of these medications. And finally, to gain some insights into the multidisciplinary nature of treatment in eating disorders and also learn some techniques in terms of how to support integration of medication into treatment. So to start briefly, I'd like to talk about anorexia nervosa. It does stand out a bit in the field because it's one eating disorder that has the highest mortality rate amongst all psychiatric conditions. Anorexia, unfortunately, is prone to very frequent relapse rates. It's considered a chronic and severe mental illness. And as some of you may know, has a very high disease burden associated with it. This is both from on a personal level, familial level, and also the wider healthcare system, society. There's a very high cost of treatment associated with it. Oftentimes, a hospitalization for anorexia is in the order of weeks, if not months. And very often, individuals need to travel to access specialized treatment because there are a lot of clinicians who are simply unfamiliar with how to manage some of the acute symptoms of anorexia nervosa and the medical complications of them. There's usually a need to consult a specialized team or even travel to obtain that level of care. To this date, no medication has been approved for the treatment of anorexia nervosa, and yet a large proportion of individuals with anorexia are treated with psychotropic medications. Here we look at a brief history of some medication trials throughout the years since the 70s. This slide is not comprehensive. This is just 14 separate trials. There have been more, but it's there to illustrate that it hasn't been for a lack of trying. In fact, almost every single medication class has at some point had a trial to assess its viability in the use of anorexia nervosa, from ciprofloxacin, appetite stimulant that's is still used today, to antidepressants like amitriptyline, clomipramine, Prozac, to supplements like zinc, which initially showed some promise, to antipsychotics, mood stabilizers, 9-THC, which is the active ingredient in marijuana. So it's been used in the 80s, to Xanax, alprazolam, other antipsychotics, and the ghrelin, the hunger hormone. There have been a lot of trials, and unfortunately, none have yielded substantial benefit to be recommended for treatment of anorexia nervosa. Today, there are only two medications that are FDA approved for the treatment of eating disorders. That would be Prozac, which is fluoxetine for bulimia nervosa, which has been shown to decrease the rate of binging and purging, and lisdexamfetamine, which is Vyvanse, approved fairly quickly for the treatment of binge eating disorder after binge eating disorder was incorporated into the DSM. If we were to postulate some of the reasons why there are only two medications approved so far, we can look at this graphic to look at the rate of how our federal research dollars are being allocated. And I've used this graphic to compare, this is federal research dollars per affected individual. For schizophrenia, about $87 per affected individual; autism, $58.65, and 73 cents per affected individual with an eating disorder. This is not to say that schizophrenia and autism don't need those funds. They absolutely do, but this is just to highlight where we're at in terms of the amount of attention that eating disorder research is receiving from the federal government. And this is data from the U.S., but the numbers don't look very different across any countries. It looks the same in Canada, looks the same in Europe. This is really a worldwide kind of underfunding of research in the field. So there is a significant gap between the public health burden of eating disorders and the current state of research to investigate some of these novel treatments. So this is where, I mentioned that there's a significant portion of individuals with anorexia are in fact receiving treatment on psychotropic medications. This is where we talk about some of those treatment targets. Well, it's the co-occurring conditions. For some who work in the field, it might be evident that very rarely do eating disorders exist in a vacuum. In fact, for an eating disorder to come along with a comorbid condition is generally the rule, and it's rare that that's not the case. These are some of those comorbid conditions, from anxiety to mood disorders to impulse control to substance use disorders and personality disorders. I've named these top 5 just because this is where we have data in terms of prevalence studies. There are obviously a lot more, which is why this list continues below the screen. So looking at some of the data that we have available regarding the prevalence of these co-occurring conditions, anxiety disorders are the most common. More than 50% of cases of anorexia nervosa, bulimia, and binge eating disorder were found to be prevalent with, to be comorbid with anxiety disorders. Of those, generalized anxiety disorder was the most common condition. Mood disorders such as major depressive disorder also exist in over 50% of cases in anorexia nervosa in multiple studies, up to 50% in bulimia nervosa, and in one study, 33% of cases with binge eating disorder. And again, this to me highlights some of the really lack of data, because I think these numbers are in fact conservative versus what probably exists in reality. One study of 2,400 in patients with an eating disorder showed that 94% had a history of a mood disorder. That was primarily major depressive disorder, and 36.7% had a history of self-harm. And we also have data on impulse control disorders being comorbid with eating disorders. Classically, in adult psychiatry, impulse control disorders include intermittent explosive disorder, conduct disorder, even something like kleptomania that were included in this study. And you can see that, again, we have very high comorbidity rates. I'll talk in the next slide a little bit about ADHD. One study that identified, I believe it was a study out of Europe, that up to 25% of patients with eating disorders do meet criteria for ADHD. We actually don't have great prevalence studies on the comorbidity of ADHD, even though I can tell you in my line of work, I'm seeing a lot of ADHD being comorbid with eating disorders. The studies that we do have available showed that there's a 3.6 times higher likelihood of developing an eating disorder in adolescent females who have been diagnosed with ADHD. And that ADHD, given the timeline of its development, usually in early childhood and early teenage years, may be a predictable risk factor for development of eating disorders, and that its severity may predict worsened outcomes in eating disorders. Obsessive compulsive disorder, another major comorbid condition, has been shown to exist in up to 69% of patients with anorexia nervosa and 33% patients with bulimia nervosa. We have to talk about substance use disorders. Anorexia has been found to be comorbid with any substance use disorder, at least 27% of cases in one study. Again, I believe that to be a conservative estimate. Other common comorbid substance use disorders are often cannabis, stimulant, tobacco, benzodiazepine, and alcohol use disorders. And these are conditions that really not only complicate the treatment of eating disorders, as a lot of these substances, for example, stimulants and tobacco, can in fact be used to suppress appetite, but also complicate the medical treatment of these disorders. Severe binge eating disorder, namely, was found to be associated with alcohol use disorder. There are more other comorbid conditions. PTSD is a big one that we work with on a daily basis. 1 in 4 individuals suffering from an eating disorder also suffers from PTSD, post-traumatic stress disorder, and PTSD was found to be prevalent in more than 50% of hospitalized patients with eating disorders. Personality disorders are also very much rampant in the population. 65% of all eating disorder patients were found to have a borderline personality disorder. And in a separate study among those with anorexia restricting type, 20% were found to have obsessive compulsive personality disorder and 10% with borderline personality disorder. In the end, higher rates of comorbidity often mean greater severity, treatment resistance, and poor outcomes in eating disorders. And unfortunately, we have to talk about suicide. 1 in 5 deaths related to anorexia nervosa is in fact due to suicide, which truly it's a remarkable figure that highlights again the burden that I was speaking to regarding the impact of this condition at really every system level, from the familial system to society. Individuals with bulimia nervosa are also found to be 8 to 9 times more likely to die by suicide than the general population. And individuals with binge eating disorder are up to 5 times more likely to have attempted suicide than peers without binge eating disorder. Now, I'd like to talk a little bit about the medications that are commonly used in the field, some of their uses, indications, briefly touch on mechanisms, and also some clinical considerations for both, again, both on the treatment side and the patient side. So often the five classes of medications, of psychotropic medications, are the antidepressants, antipsychotics, mood stabilizers, anxiolytics, and stimulants. And these classes are further subdivided into other classes, which you may have heard about: SSRIs, SNRIs. I'm going to kind of go into look at these individually and do a brief overview of the different classes. So starting with the treatment of co-occurring anxiety disorders, and this is, again, co-occurring anxiety with an eating disorder. First line treatment is typically with SSRIs and SNRIs. It's important to note that this is a talk focused on medication. So I don't talk much about therapy, but really first line treatment is therapy, specifically cognitive behavioral therapy. And the role of medications is really as adjunct with therapy. And all of the studies demonstrate that the best outcomes are when a medication is combined with a therapeutic modality. SSRIs are selective serotonin reuptake inhibitors. These are medications that have been around for decades at this point, commonly fluoxetine, Prozac, sertraline, Zoloft, escitalopram, Lexapro, Luvox, Paxil, and Celexa. SNRIs, which are sometimes interchangeable with SSRIs, although have been found to have slightly higher side effects associated with them, would be Effexor, Pristiq, Cymbalta, among some of the more commonly prescribed ones. Just to briefly talk about the mechanism, due to the inherent complexity of the brain where a lot of these medications work, the exact mechanism of action is, in fact, not so clear, but we have theories, we have hypotheses. So for SSRIs, for example, the idea is that they increase the availability of serotonin, which is a neurotransmitter that plays multiple roles in the brain, from mood regulation to cognition to learning to memory, and has been implicated as one of the systems that has shown benefit and improvement of anxiety and depression as well. If we look at the graph here on the right side, so essentially serotonin works at this synaptic cleft between the neuron and the synapse, and the role of the serotonin is to communicate between the two. And Prozac on the right side is the small green sphere, which acts as an inhibitor of this big purple reuptake channel. So reuptake essentially means deletion of the serotonin. Typically, the serotonin hormones are reabsorbed at the synapse, but by Prozac blocking that reabsorption, it allows for availability of more of these little spheres, which corresponds to the serotonin. Now, again, I want to emphasize the mechanism is not so simple as this graphic demonstrates. And in fact, serotonin is not the only neurotransmitter involved in the action of SSRIs, but this is just how we kind of have theorized the mechanism of these medications. The length of onset of the effect of SSRIs is typically in the order of weeks, if not months. I would say 4 to 6 weeks is a conservative estimate. A secondary effect of having more serotonin available is typically there's also generation of more serotonin receptors, which can take weeks. Although I would say that's not kind of a hard and fast rule. There are many times where patients will tell you within the first couple of weeks that they're noticing an improvement in some of the initial presenting symptoms. There are some side effects associated with the use of SSRIs and SNRIs. The common ones are gastrointestinal distress. Over 90% of serotonin actually exists in the intestinal lining of the GI tract. So initially, when starting these medications, there can be some sensitivity in the gastrointestinal system. Typically, it's transient, it's short-lived, and it does go away after the first few days. In some cases, it doesn't, which is a treatment, I would say, failure in that case. A second common side effect happens in some studies. About 20% of cases is sexual side effects. This can happen with really every SSRI antidepressant, and it's one of those side effects that clinicians may not find out about unless you're asking about it, because it can come along with shame and sometimes even just not knowing that it could be related to the medication itself, which is why it's important to always provide that education at the onset. And the sexual side effects are can consist of loss of libido, but also of performance difficulties as well. And a very common cause of discontinuation of antidepressant therapy. So again, very important to be addressed. And then there's a long list of what I would consider to be kind of broad, non-specific medication-associated symptoms like nausea, headaches. I always encourage individuals starting these medications to keep account of what they're noticing, and not necessarily read the label because it's a long list, but really GI distress and sexual side effects are the ones that are common with this class of medications. There are other agents that are often used for treatment of anxiety. I'll just briefly go over some of them. Benzodiazepines are controlled substances that modulate GABA. Klonopin, lorazepam, alprazolam. These are medications that I think used to be used more often in the early days of kind of medication management for anxiety, but nowadays primarily reserved as rescue medications. Why? Because they have significant side effects associated with them. They can be sedating, they can be disinhibiting, and they can be habit forming and addictive. Buspirone, Buspar is another class of medication that's a serotonin agonist, can be used, doesn't have many side effects associated with it, but anecdotally can also kind of be hit or miss in terms of its actual therapeutic benefits. Antihistamines like hydroxyzine and Benadryl are also often used. These are anticholinergic medications that can be used on an as-needed basis. They don't have to be taken every day like the SSRIs and SNRIs to be effective. But important to note that they also have side effects such as sedation. And in our field, antihistamines may also have an impact on appetite. They can increase appetite, which is something to keep in mind depending on the particular individual that we're working with. Gabapentin and pregabalin are often used off-label for treatment of anxiety. These are classically anticonvulsant medications that decrease abnormal excitation in the brain by their work on calcium channels that are involved in neurotransmitter action. Beta blockers have historically been used for performance anxiety, but can also often be used on a day-to-day basis for individuals who've usually failed other classes of anxiety medications. It's important to consider beta blockers do have a significant impact on heart rate and blood pressure. And for an individual, for example, with a restrictive eating disorder like anorexia, who may already suffer from bradycardia, a very low heart rate or blood pressure, a beta blocker may not be an ideal choice. This is a medication that really works on the physical aspect of anxiety rather than the underlying psychological causes of anxiety that serotonin modulators may work on. And then there are also some alpha agonists like clonidine, which can be helpful in management of anxiety, also can cause some level of decrease in blood pressure. Antipsychotics have also demonstrated a positive effect on anxiety management, namely quetiapine and olanzapine. These are antipsychotics that have a significant antihistaminic profile associated with them, which can explain why they can be helpful in some aspects of anxiety management. Important to note, antipsychotics have significant metabolic side effects associated with them that I'll get into in a few slides. And then an older category of medications that I won't be talking about much are tricyclics, that's the TCAs, and the monoamine oxidase inhibitors. These are an older category of antidepressants that do have increased severity of side effects, significant dry mouth, blurry vision, urinary retention, and can be lethal in the case of overdose, which is some of the reasons why they're really rarely used these days in the field of, I would say, psychiatry in general. Also mention some SSRIs like venlafaxine can have an impact on blood pressure. It can actually increase blood pressure. So it's always important to consider really, doing a comprehensive psychiatric assessment includes really assessing the current state of health of an individual, the medications that they're currently taking, to be able to then cater and personalize essentially the side effect profile of some of the medications to mitigate risk. Moving on to treatment of mood disorders, starting with unipolar depression. Again, SSRIs are first line. That's the Prozacs, the Zolofts, the Lexapros, along with therapy. Then we have SNRIs. These are medications that work on serotonin and norepinephrine reuptake. Again, allows for availability of more serotonin and norepinephrine at the synaptic cleft in the brain. There is a class of atypical antidepressants, bupropion, which is Wellbutrin, is a common and a very effective antidepressant for treatment of depression. Mirtazapine or Remeron is another one, which is considered an atypical. And then there are some newer ones that have arrived on the market recently. Auvelity was just, I believe, was approved in the last year or so, is a combination of bupropion with dextromethorphan, which has been approved for treatment of major depressive disorder. Zurzuvae is the most recent antidepressant. In fact, the first oral medication to be treated for postpartum depression, which is really wonderful because it only needs to be taken for 2 weeks postpartum. And it can very often act as a bridge for someone who may be either prone to postpartum depression or experiencing the symptoms, and to act as a bridge toward use of something like an SSRI, which often takes longer to take effect, in order of 4 to 6 weeks. Then there are the serotonin modulators, again, newer class of antidepressants. These are medications that don't just prevent the reuptake of serotonin, but actually work on the serotonin receptor itself. Vortioxetine and vilazodone are some of the newer ones that are currently being used on the market. The NMDA antagonists, ketamine is being used off-label. It doesn't have any indication for psychiatric conditions, but ketamine infusions have been found to be effective. Ketamine has been used for many, many years as a dissociative anesthetic in emergency rooms, and also as a party drug for decades. And more recently, the NMDA system has been found to be implicated in mood regulation. Esketamine, which is the branded under Spravato, which is the intranasal form of ketamine, it has received an FDA approval for treatment of depression that has been resistant to any other medication trials. These are medications that work as a competitive antagonist of the NMDA receptor instead of glutamate, and are particularly effective very rapidly. And in fact, a lot of studies have shown that they can very quickly alleviate acute suicidality, which if you can imagine, can have really a significant positive impact in terms of management, in the field of suicidology and psychiatry in general. Again, we have the TCAs and the MAOIs, which have historically been used for management of depression. And then there are some atypical antipsychotics that have FDA approval to be used as adjunct treatments for depression. This is just a handful of them. There are more that have received that FDA indication. And some of that has to do with the serotonergic action of these antipsychotics that I'll get into very soon. Abilify, Latuda, and Rexulti are some. Symbyax is a combination of fluoxetine and olanzapine, which is approved for bipolar depression. Some clinical consideration in management of depression with a co-occurring eating disorder. It's important to note that as effective as bupropion is as an antidepressant, it also has significant appetite suppressant properties. In fact, in some venues, bupropion is used as a weight loss medication. So this is important to bear in mind when dealing with restrictive eating disorders. and the role that Wellbutrin can take in increasing some of those challenges that come along with weight restoration and recovery. Now, Wellbutrin has also had a bit of a bad rep in eating disorders because of some early studies that showed that it was particularly implicated in lowering the seizure threshold in individuals with anorexia and bulimia. I would say there's some nuance here because Wellbutrin always has this property of lowering or decreasing the seizure threshold in someone who may be prone to seizures or who may suffer from a seizure disorder like epilepsy. But the studies actually showed that it would really need to be very high daily doses of Wellbutrin in order for that seizure threshold to be reached, in order of more than 450 milligrams and closer to 600 milligrams per day, which really is higher than most psychiatrists and psychiatric clinicians use for management of depression. So the nuance is that, being an effective antidepressant, if an individual if Wellbutrin is the lifeline, it may not be a good idea to move toward a quick discontinuation simply because of that side effect. Mirtazapine, one of the atypical antidepressants, is a frequent appetite inducer, and that's can actually be pretty remarkable in terms of its ability to cause weight gain. I say here appetite inducer, but the exact mechanism of how mirtazapine leads to weight gain is not completely clear. What we do know is that not only can it improve appetite, but it also plays a role in lipid metabolism and the brain's response to gastrointestinal hormones like ghrelin, essentially causing a very high hunger urges due to the desensitization to ghrelin in the brain. Antipsychotics have a similar effect, and again, with a multifactorial mechanism by which they can affect weight gain. Antipsychotics also affect glucose metabolism and stomach motility, intestinal motility, which can cause metabolic syndrome. TCAs and MAOIs, like I mentioned previously, they can also cause an increase in appetite and weight gain, but they also have significant side effects and can be lethal in the case of an overdose. Just to briefly talk about the nutritional theory of serotonin availability, this is a common question that comes up. There were some early suggestions in the literature that in individuals with anorexia, SSRIs and SNRIs are less effective because of a lack of nutritional kind of fed state of the brain. And this was related to the lack of tryptophan, which is a precursor molecule for serotonin. In looking at the literature, this is very much inconclusive. There were studies that actually supplemented tryptophan along with SSRIs in individuals with anorexia nervosa, and that was not found to be helpful in regard to improving outcomes with SSRIs. So I would say that this is not kind of so black and white, and I don't routinely recommend not trying SSRIs or SNRIs simply on the assumption that, well, there's not enough serotonin to work with to begin with. And finally, typically the amount of time an individual would need to be on antidepressants is in the order of months. Specifically for major depressive disorder, it's actually 8 months and above. I usually like to start with 6 months and up because 8 months can just sound very intimidating to a lot of individuals. But most of the studies have shown that early discontinuation of antidepressants, in fact, leads to high rates of relapse. So individuals who just feel better after a couple of months and feel like they can stop taking their medications are unfortunately at risk of high rates of relapse. Other forms of mood disorders would be mania and manic episodes. There are mood stabilizers used in this in management of mania, such as lithium, Depakote, Lamictal, carbamazepine, to name a few. There are also atypical antipsychotics that have FDA approval and indications for management of mania and also bipolar disorder. I've named some of them here. I won't go into each one of them individually. And benzodiazepines, such as Ativan, Klonopin, are also very effective in the management of the acute stage of a manic episode and the symptoms of mania. Important to consider that as effective as some of these medications are in terms of mitigating the risks that are actually quite high with manic symptoms, they can also have significant side effects, which is why monitoring is very important. Lithium, for example, has a significant effect on the endocrine system, including the thyroid and the adrenal glands, as well as the kidneys. So lithium monitoring in the blood is very important as it has a very narrow therapeutic window. Antipsychotics and mood stabilizers, as I mentioned, can be associated with weight gain, and that's essentially all of them that have that association, some more than others. Benzodiazepines can cause disinhibition, which can pose a challenge to intuitive eating, along with some of the habit-forming side effects and sedation that I mentioned previously. And also, I wanted to briefly mention antipsychotic-induced constipation. This is primarily, I would say, concerning with one antipsychotic called clozaril, where it can actually cause total intestinal paralysis, but you do see it in other kind of lesser forms of antipsychotics as well. So important for there to be good communication with a dietitian and a patient regarding potential side effects of antipsychotics when they do play a kind of a critical role, such as management of mania or psychosis, as I'll speak about next. So antipsychotics are actually used in a lot of different conditions. So it can be bipolar disorder, schizophrenia, schizoaffective disorders, major depressive disorder can come along with psychotic features, but obsessive compulsive disorder, Tourette's, BPD, substance-induced symptoms. They're typically broken down into an older category called first-generation antipsychotics, with thorazine and haloperidol, thorazine being the first antipsychotic that was discovered in the 60s, and newer second-generation antipsychotics, such as risperidone, Abilify, which is aripiprazole, and olanzapine. There are newer second-generation antipsychotics that have come on the market in the last few years with slight modifications in their mechanism, such as brexpiprazole, which is sort of a new generation Abilify, cariprazine, and lumateperone. But the essential mechanism is really the blockade of dopamine receptors. Both first and second generation antipsychotics work on various dopamine receptors, primarily D2. The difference being that the second generation antipsychotics, due to having lesser antihistaminic and cholinergic effects, typically come with less side effects. And some of them also have a partial dopamine activating profile, such as Abilify and brexpiprazole, which can be helpful in working with some of the negative symptoms of some psychotic conditions, as well as major depressive disorder. And they do work much, much faster than, for example, SSRIs that can take in the order of months. Antipsychotics have been used off-label to reduce eating disorder-related ruminations, as well as some compulsive behaviors in the setting of OCD and OCPD. There's still some ongoing research in terms of use of antipsychotics in this area. ADHD is kind of a, I would say, a bit of a controversial topic. Some believe it's routinely overdiagnosed, and some would say it's actually underdiagnosed. When it comes to co-occurrence with eating disorders, there are certain factors to keep in mind. So before we get into that, so the general treatment for ADHD is broken down into two categories: the stimulants and the non-stimulants. Stimulants consist of methylphenidates and amphetamines, and there's about 30 different ADHD medications currently on the market. And it's really different variations of a theme, different durations of effect, different formulations. But they all really implicate the dopaminergic transmission pathway. And the non-stimulants that exist include atomoxetine, which is Strattera, Qelbree, which just came on the market a few months ago, clonidine, and guanfacine. And those actually work with the norepinephrine system. Important to note that all stimulants, as effective as they are in the management of symptoms of ADHD and improvements in executive function, can be significant appetite suppressants. Generally, at higher levels of care, it is recommended to work with an individual to generally discontinue or minimize use of stimulants until a significant amount of weight restoration has been achieved. Typically 90%, 90%, 90% is of IBW has been used. And this can vary. Some would actually, I personally like to reserve that conversation for lower levels of care, such as outpatient. When I feel, and again, this varies on a case-by-case basis. Important to note the potential contribution of stimulants to anxiety, right? They have very real physical side effects, such as tachycardia and increasing the rate of heart rate, which can also pose an increased cardiovascular risk for an individual with an eating disorder who's already at risk of stress to their heart. Stimulants can pose kind of a second line stressor to the heart and other organ systems. And I want to, it's important to also place this risk along with the potential benefits, right? Because there's also a lot of studies, as I showed earlier, that demonstrate how unmanaged ADHD can worsen outcomes in eating disorders. And it does have a strong association, particularly with binge eating disorder. Atomoxetine, which is a non-stimulant, the Strattera, also has significant appetite suppression associated with it. Although I will say, due to its work on the norepinephrine neurotransmitter system, it can actually improve some symptoms of anxiety. It is important to screen for eating disorders prior to treating ADHD, just to make sure that the treatment is sort of not neglecting a potential restrictive eating disorder that would suffer from aggressive management of ADHD. Just to do a bit of an overview on psychiatric medications that have an impact on weight and appetite, and this again may not be a totally comprehensive list. Wellbutrin, bupropion, as I mentioned, has significant appetite suppressing effect and can cause weight loss. Contrave is a combination of Wellbutrin and naltrexone, an opiate antagonist, which again used in some settings for weight loss. Topomax, which is an anticonvulsant, can be used as a mood stabilizer, has significant appetite suppression associated with it, and in fact, sometimes even prescribed with an antipsychotic to mitigate some of the appetite-inducing effect of antipsychotics. All stimulants have appetite suppression associated with them, and Strattera does as well. Now, some of these medications may in fact play a positive role in terms of allowing for intuitive eating in a condition like binge eating disorder. But again, this really is variable. None other than Vyvanse have really been have that indication, at least from the FDA, or have been shown promising results to a significant level. And then the appetite inducers or weight gainers can be mirtazapine or Remeron. I put that on top because in my experience, and according to a lot of studies, it is the most significant in terms of causing remarkably kind of sudden and acute weight gain. All antipsychotics are associated with metabolic syndrome and weight gain. Mood stabilizers, I would say the majority, if not all, have weight gain associated with them. Paxil or paroxetine is one SSRI, which has weight gain associated with it, and so do the older TCAs and MAOIs. Now, using or considering using a medication that may promote weight gain or stimulate appetite may in fact intensify some of the cycles of anxiety restriction, binge purging that comes along with a lot of the restrictive disorder. So this is something to keep in mind, and why generally we don't recommend use of these medications for weight restoration. Some universal medical considerations that I'm going to go over quickly is the importance of cardiac monitoring. Some medications, including antidepressants and antipsychotics, may prolong QTc, which is a measure of cardiac electrical conduction, which can be measured on an electrocardiogram. And this can be an indication for a risk of a fatal arrhythmia. Now, this is very rare, extremely rare, but important to monitor and important to pay attention to as the primary clinician. This risk of cardiac complications is often amplified because of electrolyte abnormalities that come along with various forms of eating disorders, particularly with potassium. Right, potassium decrease can also cause an increase in the QTC, which, on top of use of a medication, can really kind of escalate some of the risk factors in some of these eating disorders. Important to pay attention to polypharmacy, right? If someone's on more than 4 medications, you really have to take a critical eye as to why, and consider drug-drug interactions in those cases. And I'll get into that a little bit in a follow-up slide. The renal function, kidney function, and liver function of individuals is very important, right? You have some level of impairment of both kidney and renal function renal and hepatic function in various forms of eating disorders. And a lot of the medications are metabolized through these 2 organs. So important to consider dosing and paying attention to the state of health of the individual. And finally, withdrawal from certain medications as well as substance abuse can significantly impact and complicate treatment and the associated risks here, which is why a lot of times a urine tox screen can be helpful, and really working closely with the patient to understand what is kind of being put into the system to make sure we're mitigating the risks associated with some of the medications. So here I'd like to talk a little bit about personalizing treatment. And I do think this is probably one of the more important aspects of this whole talk. There is really no one-size-fits-all approach. In psychiatry, there's not an algorithm that we use where every single person would benefit from a same medication, for example. And this is important. You may have heard a lot of kind of resistance to medications from a lot of individuals. I don't want to be on a medication for the rest of my life. I don't want to become dependent on anything. I could do this myself. I've seen medications turn people into zombies, or I don't want the medication to change who I am. These are common and I would say valid experiences from individuals who take medications. And it's extremely important to pay attention to that subjective experience of the patient, as well as family members and other loved ones involved in someone's care. And in the end, not everyone does benefit from medications. It's important to kind of put that out there. This is not for everyone, but it can be a lifesaver for those who would benefit from them. To briefly talk about the psychology of psychopharmacology, so patient non-adherence to medications is actually a significant barrier to effective treatment. And that's just really, I'm talking about not consistently using a medication. And this is not just in the field of eating disorders, but individuals with bipolar disorder, depression, schizophrenia really do suffer needlessly because of this difficulty of consistently taking a medication. So just to touch on a few different pointers here. So it's good to accept that ambivalence about taking medications is actually the norm. And not the exception. I'm a psychiatrist. I don't like taking medications. I don't want my children to take medications unless there's a very clear benefit as to why it's needed. The therapeutic alliance has been shown time and time again in different studies to be correlated with positive treatment outcomes. And what is the therapeutic alliance? It, in essence, is how much the patient trusts the clinician, and also how much the patient likes the clinician. Does the patient feel heard? And listening really has to be bidirectional here. It's very hard to expect an individual to just accept a recommendation from a provider, from a clinician, if they don't feel that they were truly heard. If when they were describing some of the challenges that they have or their life story, unless they feel heard by you, they're a lot less likely to want to essentially follow or listen to your recommendations regarding potential solutions to some of the challenges that they've described. So listening is very much an art, and certainly in a lot of different, I would say, settings in medicine, a lost art, but something that's critical if we are to address this issue of medication non-adherence and consistency. There is strong evidence that psychological and interpersonal factors have a significant effect in psychopharmacology, and this goes way beyond just the direct pharmacological action of medications. Finally, the placebo effect is responsible for 30 to 40% of response rates in a lot of the outcome studies and the medications that I've already discussed. And this is quite, I think, remarkable and significant to pay attention to and try to leverage as a positive force in treatment. When working in a setting that really emphasizes patient-centered care, there are various members of the team that do have an opportunity to help an individual integrate medication treatment, or even if they're just considering medications. And some ways of doing so would be to try to identify barriers that the individual is going through. Sometimes they're not communicative about them. Sometimes they don't like to discuss them with the actual prescriber. So different members of the team, simply by asking if someone's taking their medication, can really be attuned to some of those challenges and help troubleshoot them. Some very basic logistical solutions would be use of medication reminders, right? That would be like an alarm on a cell phone, or even during a session. Just basic reminders, helping someone with developing routines, just like brushing their teeth, right? If someone really is dependent on taking a morning antidepressant to be able to function, it's important to try to incorporate some of those daily routines. And also pillboxes can be very helpful. There are certain medication side effects that can be addressed with adjustments in a meal plan, such as, for example, heartburn or constipation that could be as a result of a medication. Certain medications need to be taken with a meal. So even just slightly adjusting the timeliness of a meal can help with medication administration. And also the different team members also have an opportunity to recognize behavioral or physical side effects of medications that either a patient may not report, forget to, or not have the opportunity to report to the psychiatric clinician. Another aspect of personalizing treatment is really paying attention to the family history and the genetic makeup of an individual. This is significant. DNA sequencing previously was very cost prohibitive, but now there are a handful of commercial companies that are working with insurance providers, including Medicaid and Medicare, to approve these pharmacogenomic studies. So essentially what it is that it provides a metabolic profile for all psychotropic medications for an individual. And this is information that's based on an individual's DNA and does not change. So it's like a living document that exists for many, many years and can help guide the dosing of some of these medications. Important to note that this type of testing is not routinely recommended because it says nothing about what medication is effective or more likely to be beneficial, but it does let us know if someone is a slow metabolizer or a fast metabolizer of a particular medication, which can indicate how likely it is that they may experience side effects associated with a medication. So there are certain candidates for these tests, usually someone who's either failed a lot of medications in the past or has been prone to a lot of side effects and sensitivity to medications may benefit from this type of testing. It's as simple as a cheek swab that's put into a test tube, submitted to the company. They do the DNA sequencing and the results are available usually within a week. Want to make sure I have enough time to talk a little bit about deprescribing. This is a phenomenon that's kind of originated in the field of child and adolescent psychiatry, but I believe applies just as well to adults and really every individual who is taking a medication. In our kind of disjointed healthcare system, a lot of times you have an individual who might be at a certain level of care for just a few days, just a few weeks, and then they go back to their outpatient provider, and then they go into another level of care. And there is not cohesive communication amongst those essentially clinicians and prescribers. So the prescribing is a structured approach to identify and discontinue medications when risks actually outweigh the potential benefits of those medications. Sometimes I inherit a case that comes in front of me and they might be on 6 different medications, and frankly, it's unclear why and what the initial indication was as to why a medication was started. it was essentially kind of set and forgotten for months, sometimes unfortunately years, which is why the practice of deprescribing can be so valuable to decrease harms. So doing a comprehensive psychiatric assessment is extremely important. Ensuring cohesive communication among an individual's outpatient team members, especially when there are multiple prescribers, and whenever possible to review the past treatment record is really critical to make sure that we are really decreasing the risks of harm associated with certain medications. Polypharmacy should be avoided at all costs. Like I said, typically more than 4 medications may be considered polypharmacy. This causes an increase in side effects. Consider deprescribing when a medication does not have a clear indication for its use, has been ineffective for the symptoms that it has been targeting, or those symptoms have resolved for or are in remission for a good amount of time. They're being prescribed outside of recommended dosing guidelines. A common scenario, the medication has insufficient benefits to justify its side effects. So when talking about some of these antipsychotics, you really have to feel that there is a benefit to it before justifying its use. And also make sure that the medication is not used as part of a prescribing cascade. So that's when a side effect of one drug is actually misconstrued as a symptom of a disorder. So if an individual is on multiple antipsychotics and suddenly engaging in a lot of binge eating behavior, could be easy to make a new diagnosis, or you can pay attention to the actual side effects of the medications that are currently being taken. And also drugs that are used to counter the side effect of another drug. This is the prescribing cascade that should be avoided. All right, so moving on to future directions. Just to briefly talk about what may be next for the field. So certainly there are a lot of challenges with eating disorders. There is a complex interplay of the biopsychosocial factors that lead to the development of these conditions. And looking at just pharmacology and medications, we might address the biological factor without making a dent in the psychosocial factors. So this work does not exist with just medications. It really has to, and this is why we do the work that we do as a multidisciplinary team, but that complexity certainly poses a challenge to the treatment of these disorders. There's also the inherent complexity of the brain. A lot of the medications that have been discovered and are currently being used actually were discovered serendipitously. And it's very difficult for researchers to have kind of a mechanistic hypothesis which they then implement by conducting research. A lot of times it's a happy accident that leads to the discovery of these medications, and that's because of the complexity of the brain. We're talking about millions of neurons and synapses and neurotransmitters that are involved at every single one of those areas. We don't really have great models to understand the brain at this point. Big Pharma has somewhat withdrawn from the field. Some of the risks associated with some eating disorders, when we talk about suicide, it does pose a challenge to large-scale clinical trials in the field. And that usually means loss of dollars when it comes to research. The egocentric nature of anorexia nervosa in particular is a significant challenge. This is a disorder that makes it so that a lot of individuals, in fact, don't have a high level of motivation to get better. And this becomes difficult, even if there is a medication that's likely to address a lot of the comorbid variables that can facilitate recovery. This egocentric nature of anorexia makes it that they're less likely to want to accept that treatment. And finally, the nutritionally starved brain. I think I'm looking forward to a talk this afternoon by Ronnie on some of the cognitive effects of eating disorders. Certainly, there are limitations that are posed on the brain in terms of cognitive abilities. And it goes without saying that food really is the best medicine in order to recover from, especially the not just the restrictive, but really all eating disorders. There was some kind of promise that was, in the headlines. There was 20 plus trials on olanzapine that demonstrated some positive results and outcomes in terms of weight restoration. A lot of seasoned clinicians in the field would see this as problematic because of some of the side effects that I mentioned and the potential impact of medication causing artificial weight gain or increase in appetite, causing not only worsening of anxiety, but that those gains would be very short-lived, and it may be positive in a trial, but not really impactful in the big picture of someone's recovery trajectory. There is some, I would say, in the last few years, some kind of fervor and excitement around a federal ban on psychedelic research that has been lifted. Firstly, ketamine and esketamine are being used in some aspects as effective treatments for some of the comorbidities, but also directly for use of eating disorders. And also with psychedelics, psilocybin, the active ingredient in magic mushrooms, MDMA, they're currently undergoing some trials. And this is, in fact, I think, interesting and exciting because these active ingredients are not being used as a means to an end on their own. And in fact, they're being used to assist with therapy and specifically address that, what I mentioned as the egosyntonic nature of a condition like anorexia nervosa, because they're not treatments that need to be taken, it's not a daily dose, but rather used in short form to align an individual's motivation and perception and ability to view a version of themselves who is capable of recovery, who is capable of committing to recovery and has a potential for a life that has not been lived. And this is that stuckness in some of these conditions that extremely treatment resistant, quote unquote. So there's certainly some promise here, not to say that some of these ingredients don't come with some risk as well, which I'm not getting into right now due to time. And then finally, GLP-1 and GLP-1 receptor agonists, they've been very effective in some areas. They may potentially show some promise in addressing conditions like binge eating disorder and to allow for lessening the noise that sometimes is associated with these conditions and to allow for intuitive eating. Remains to be seen, but I think it's always helpful to keep hope that there are promising innovations in the field of eating disorder recovery. And I'll stop there. Hopefully I'm okay on time, Jamie, so we can have some time for Q&A.
We are actually out of time. Dr. Moss, thank you so much for your presentation and all of that amazing information. We did have a couple of comments and questions for you in the chat, but if you would be so kind as to share your email, then we can have our attendees email those questions to you, if that's okay.
Absolutely. I'm going to write my email in the chat. It's smoss@withinhealth.com.
And you are getting a lot of praise, very informative. They're thanking you. They are saying that this presentation was one that was very needed. And the only complaint is that we just didn't have enough time.
Thank you. Thank you for being with me this morning. And I hope you all have a great rest of Summit.
Thank you so much. And we'll see you all on the next session. Thank you, Dr. Moss. Have a wonderful day.